Hey guys, this is Brenda, owner of Zackel & Associates. In the last video, you learned about physiological effects of lithotomy positioning, best practices, and special considerations. This week, you will gain a better understanding about the sitting and semi-sitting position. It is important to collaborate with the surgeon to determine if the sitting or semi-sitting position is most appropriate for the patient and procedure. Patients may be placed in this beach chair or Fowler's position for procedures involving the shoulder, posterior cervical spine, and posterior or lateral head. The sitting and semi-sitting positions place extra pressure on the sacrum, scapula, back of knees, ischial tuberosities, and calcaneae. Apply padding to the buttocks to help prevent undue pressure on the sciatic nerve and the coccyx. The patient's hips are flexed 45 to 60 degrees, so it is essential to flex the knees 30 degrees to reduce stretching of the sciatic nerve. This also helps to prevent postoperative neuropathy. Physiologic complications a patient may experience when in the sitting or semi-sitting position include venous air embolism, which can occur in a surgical position where the surgical site is higher than the right atrium, unstable blood pressure, and decreased venous return from the lower extremities, which can lead to pooling of blood in the patient's pelvis. Maintain the head and neck in a neutral position that is in line with the sagittal and coronal plane without excessive flexion, extension, or rotation. Elevation should be reduced to decrease the incidence of hypotension and subsequent cerebral desaturation. Based on the needs of the team and physical limitations of the patient, the OR staff should position the arm so that the non-operative arm is flexed and secured across the patient's body, usually in a sling or on an adjustable height armboard. If possible, prevent the pannus from resting on the thighs. Use a wedge under the legs against the buttocks to prevent sliding. Use SCDs or sequential compression devices to increase venous return from the lower extremities and prevent venous pooling. The sitting and semi-sitting positions should not be used with patients with VP shunts. In the case of a venous air embolism, the OR team should be prepared to detect and implement interventions to handle this scenario. Did your client suffer from a deep tissue injury, joint dislocation, or nerve damage due to a surgical positioning error? Let our legal nurses at ZALNC educate you on your client's injuries. This is Brenda Zackel, bridging the connection between medicine and law.